session we have discussed about the large vessel and medium vessel vasculitis conditions. So the next as a sample of the small vessel disorder, and that's there the more common and what we see almost frequently in our clinical practice is henox-inline purpura, or it's also called as immunoglobulin A vasculitis. It's a systemic inflammation of small vessels caused by an acute perivascular deposition of immunoglobulin A and activation of the neutrophils. It's a sort of inflammatory pathology, but often induced due to autoimmune phenomena. Etiology of this is not clearly defined, but it's thought to be due to multiple factors, even genetic, environmental, and antigenic components. But most frequently, what we see are of the antigenic components. That's autoimmune pathology. Genetic tendency also is now known. As per the data, more than 70% of the patients would have upper environmental and these upper respiratory tract or GI infections initial, and once they have that episode of an upper respiratory infection or gastrointestinal infection, the next phase there would be the vasculitis like conditions. That's the common phenomena which we see, and majority of the patients would have that kind of a history, like the vasculitis phenomena or purpura phenomena has occurred after an inflammation pathology, and particularly bacterial and viral infection agents have associated with the development of these purpura, and cases have with the even medicines also. Vaccination also is known to produce these purpura. Particularly COVID vaccine, the incidence of purpura was quite high after that. It can get involved in many of the organs: skin, joints, gastrointestinal tract, kidneys, rarely lungs and CNS. More frequently what we see is the cutaneous. The skin manifestation is the one which we see more frequently. Joints is the next. GI and kidney are comparatively lesser. The typical prodromal symptoms of this henox-inline purpura is headache, anorexia, fever initially for 1 or 2 days, short duration, and it's a relatively mild presentation of fever, low grade fever, headache, and so most of the times the conditions are misunderstood as a common cold-like symptoms, and then the patient develops the symptoms typical of cutaneous manifestation, and it's almost by about a week or so, by a week or within 2 weeks it occurs. Characteristically, the most common presentation would be the skin changes, the rashes present over the legs, and it's almost in 95 to 100% of the cases, and that's the hallmark of the disease. Patients developing rashes in the lower limb, particularly lower limb. And joint pain is the next common clinical condition, and again it involves knees and ankles. When a patient having a history of fever and presenting with the joint pain, often we will be suspecting the rheumatic pathologies, and unlike that of the rheumatic pathology, the joint pain is not a fleeting nature. In the rheumatic pathology, the joint pain would be of a fleeting nature, in the sense it involves one joint and then it heals in that joint and then goes to the other joint, whereas purpura-induced joint pain tends to be continuous and progressive. It may involve initially one joint and then next the other joint could be involved progressively, but the initial early joint would not be relieved of the symptoms. Abdominal pain and vomiting is the other clinical presentation. Subcutaneous edema, scrotal edema, blood mixed stools, or edema in the lower limb with hypertension, usually in adults, are the other clinical symptoms of purpura which may occur. The characteristic skin presentation would be the initially starts with the erythematous conditions, erythematous lesions which are macular, surface would be flat, and they would not be blanching because of the involvement of the capillaries. They cannot be blanched. When you press upon these areas, that cannot be blanched, and itching is comparatively less. The patient may not even have much pain, low grade pain, and itching may be the initial mild itching could be the initial presentation, not be very much, but gradually that results in a blood-like presentation. It may become papular or superficial ulcerations. The whole area becomes sloughed out, and there could be even wound formations, multiple superficial wound formation which can occur, It can occur anywhere in the body, but more frequently in the shin, the lower limb as such. It occurs more frequently, and most of the times it's limited to the lower limb, and it also can occur in the back and buttocks in children, particularly very young children. Even the face and the trunk also can occur. Younger patients may have even involvement of the upper extremities. Involvement of the facial area is a very rare situation in such conditions. In addition to that, some of the patients may even have the gastrointestinal tract symptoms. Gastrointestinal tract symptoms like vomiting, and when the patient has that vomiting and the even occasional bleeding, a gastroscopy can be confirmatory. Gastroscopy may present with either localized edema and rashes or hemorrhagic duodenitis, extensive hemorrhagic changes in the duodenum area. In such conditions, MRI or USG also can confirm the diagnosis, but comparatively this is rare. Gastrointestinal tract symptoms are comparatively less common, but often it can produce a confusion. A patient presenting with the acute episodes of vomiting and often even blood mixed vomiting, followed by that skin rashes, and then previous history of low grade fever, you have to suspect the purpura condition, and MRI scan shows the edema in the mucosal area of the intestines. Either it could be in the stomach or elsewhere. USG also confirms the same, like there could be edema in the mucosal area. The whole organ, stomach, becomes swollen as such. That would be the findings in such conditions. The treatment for this condition is most of the times the purpura can result in continuous or progressive complications, resulting in severe tissue damage, a wound which may not heal easily, and even neurological symptoms may develop in due course of time, or it may extend from the skin to the other organs like kidney, and there could be renal pathologies. So the management of this condition would be from the point of view of clinical symptomatic relief. There is no question of any curative treatment as such known at present, and the treatment would be in the initial stage when the patient has the clinical symptoms of GI symptoms or maybe the mild symptoms of skin. The lesions or management would be mainly ensuring adequate hydration so that the patient would have sufficient fluid and electrolyte balance. So fluid and electrolyte imbalance doesn't occur, and the GIT and kidney complications have to be monitored. See, when the kidney complications and GIT complications occur, the condition becomes more severe, and hence that should be monitored, and if at all it is seen, it has to be treated or managed as early as possible. The symptoms of arthritis, edema may be treated with the symptomatic treatment, and the usual treatment which is prescribed in the contemporary science will be the NSAIDs like acetaminophen, ibuprofen and its derivatives, and if at all there is a known drug which might have induced this autoimmune vasculitis. Among those drugs, as I said earlier, vaccines are one of the common drugs which can produce purpura. Among the antibiotics, tetracycline is known to induce purpura in a significant number of patients. There could be many other drugs which also can present with the same, and often it's misdiagnosed as a drug allergy. Of course, it presents like an allergic phenomenon, but it progresses. Then corticosteroids may be necessary in such conditions where the patient may have a involvement of the kidneys and nephrotic syndrome symptoms are presented, and if the renal damage has occurred, where if the kidney tissue shows damages in the glomeruli, or the patient has severe abdominal pain, or if there is a severe gastrointestinal hemorrhage, severe soft tissue edema or scrotal edema, in such conditions treatment may be requiring the steroids administration, and patients like acute complications like neurological involvement or intrapulmonary hemorrhage, it may be necessary. The other drugs which are often prescribed in the contemporary system would be immunosuppressant drugs like azathioprine, cyclophosphamide or cyclosporine or HCl. These are often prescribed as suppressants of the autoimmune disorder. Then For the treatment of blood pressure, which is often common, angiotensin converting enzyme inhibitors are used. A dipyridamole also is used mainly for the gastrointestinal tract conditions. These days, the injection of immunoglobulin G also is becoming popular as a treatment. Danazol is another empirical drug which is often used in these conditions. But most of the patients who come to us in our hospital, they are treated with the steroids initially and they are maintained on ECQS or maybe cyclophosphamide like conditions. And as far as our clinical observation is concerned, we have treated a good number of patients with the Kashara Google Gandhakastana Khadirarista and Manjistaric Sharavasti. When there is a wound formation, Tifalakwadaparishek and that. Once the wound has occurred, the better treatment, more reliable treatment is Tifalakwadaparishek and that than any other local management as such. So that's how it can be managed. And as far as the cutaneous manifestations and the complications are concerned, our treatment definitely has a better rate than the other condition. But once the renal involvement is there, then you will have a series of complications where the antihypertensive drugs and the regime for the renal pathology, depending upon the intensity of the renal involvement, may have to be done. And even there, once the renal involvement has occurred, the prognosis becomes poor. So the caution which we have to take is any patient of vasculitis, you have to be sure that the patient doesn't have a renal involvement. Then we can manage with our Ayurvedic drugs safely. But if the patient has evidence of renal involvement, it's better to predict the prognosis or maybe express the prognosis to the patient clearly, and then we manage as such. That's about the henoxylin purpura which is often seen. The next condition related to the blood vessels is and which is again comparatively common is thromboangiitis obliterans or Berger's disease, and it's characterized by inflammatory pathology of arteries, particularly the tunica intima, and that causes a situation where the clot formation can occur because of the inflammation of the tunica intima. It can result in a platelet aggregation and clot formation occurs and results in obstruction of the blood vessels. Characteristically, the lesions are segmental, that involves only a small segment like 2 to 3 inches of a blood vessel, and medium-sized arteries are involved more frequently than the minor vessels. The major vessels like aorta rarely are involved. So, in majority of the cases of thromboangiitis obliterans, the most important characteristic feature is the involved segment is relatively shorter, not more than 6 inches any situation. So, any of the artery, and quite frequently medium-sized arteries like femoral or tibial arteries are more frequently involved, and there the segment of around 3 to 4 inches, maximum 6 inches would be involved, inflamed, and that results in a clot formation, and there would be a certain blockade as such. And initially its inflammation is limited to the tunica intima. Then the condition is very frequently associated with the tobacco use. Heavy tobacco use is considered to be one of the most frequent causes or most reliable cause for the thromboangiitis obliterans, and it also is related to the continuous use as such. The pathological changes which occur are described in the same manner, like initially it involves the tunica intima, and there is a hypothesis that simply smoking alone may not be a cause, because there are many smokers who might not have developed CAO. There could be some genetic predisposition. So because of that genetic predisposition, many of the people may have reacting to the tobacco use somewhat a different manner, and that involves the tunica intima. Initially the endothelial surface becomes edematous, and because of the edematous the condition, the platelets tend to get aggregated, and there could be a clot formation, thrombus is formed. That's how the pathology would occur. Clinical presentation and diagnosis would be it's usually a disease of the middle age, around 30 to 45 is the most frequent use age as such, and rarely it occurs at age above 45. So usually when a patient presents with these signs of vascular obstruction, if the age is more than 45, we will be suspecting atherosclerosis or the difference between atherosclerosis and thromboangiitis obliterans is in the atherosclerosis, the whole of the artery is involved. It's not only a segment, whereas thromboangiitis obliterans, one segment is involved. And this has a relevance in the outcome. Thromboangiitis obliterans conditions can be managed surgically by interventional treatment by avoiding that area, either ablution of that area or bypassing that area as such, or simply inducing a relaxation of the blood vessels by sympathectomy also can be helpful in thromboangiitis obliterans remarkably, whereas in case of atherosclerosis, because the whole artery is involved, such surgical interventions would have a poor result, and sympathectomy also may not have the same effect as such, and hence that difference is important. And one of the primary difference is age of less than 45 years and a history of smoking, either recent history or maybe continuously persisting history of tobacco use of any sort. Tobacco, again, smoking is the most frequent type of the tobacco consumption, which is responsible for the Buerger's disease. Of course, the other forms of the tobacco consumption also can result in the same, and this is the one of the important differentiation factors. Right? The other clinical symptoms will be mainly it is present in the distal extremity as such, and of course the distal extremity signs are common in atherosclerosis too, but in the atherosclerosis, the onset and the course of the disease is slowly progressive, whereas in case of the thromboangiitis obliterans, the initial there will be mild either subclinical or mild clinical symptoms of maybe low grade fever or some discomfort, which results in there is somewhat rapid onset of the ischemia. See, there the patient may have the clinical symptoms of like mild pain or mild fever like symptoms during the phase of endometrium, that inflammation of the endometrium, that is intima, tunica intima environment initially. Many times that would be asymptomatic, but once the clot is formed, there will be sudden ischemia. So that development of the ischemic symptoms are rapid in case of thromboangiitis obliterans, whereas in case of atherosclerosis, the ischemia occurs progressively. And the clinical symptoms are initially started with the claudication, then the pain at rest. Claudication, as we have discussed earlier, it's a pain produced after a certain amount of the exercise which is seen, and pain at rest. Then later it can result in ischemic ulcers or gangrene also. The important other conditions which you have to rule out are the patients with autoimmune disorders, autoimmune conditions have to be ruled out with the history. Patients who have some abnormal metabolic, these coagulative functions like disseminated vascular sclerosis like conditions have to be ruled out. Diabetes mellitus has to be ruled out by the clinical investigations. Then the diagnosis of thromboangiitis obliterans is possible. And the other that proximal heteroemboli, that embolus occurring from the heteromas also have to be ruled out by arteriography, which is standard precaution, but most of the times we do not go for the arteriography in all the conditions. And if there is as per the standard again parameter, consistent anterior findings where one segment is involved is characteristic. Other confirmatory evidences which may be done occasionally could be histological findings, blood vessels, the histology of the blood vessels, which we may not do in the regular clinical practice. We may not go for the biopsy of the blood vessels in the routine clinical practice because we can manage conservatively. But if there is a surgical intervention, then the tissue can be subjected to histopathology examination, and histopathology examination can, when it confirms a inflammatory pathology related to one segment with the minimal inflammation of the tunica media and the tunica externa, then that can be diagnosed as Buerger's disease as such. The clinical signs or appearance of Buerger's disease could be either simply pallor, the signs of ischemia, see, it is normal and the abnormal limb. The abnormal limb, the skin may be pale, or there could be even changes of that chronic ischemia, like the hair loss, the skin becomes somewhat thinned out, or there could be subcutaneous gangrenous changes, edema and subcutaneous gangrenous changes could occur, as you see, which often maybe have to be differentiated from cellulitis like condition, or there could be a frank ulcer formation, and usually that frank ulcer and gangrene formation would be at the periphery. The arteriography confirms the pathology. Characteristically, the arteriography shows one segment being involved, and then the effective collateral circulation. See, there in this arteriography, the medial artery has become completely obliterated, one segment up to 60 inches. But there is a collateral circulation. Beyond the collateral circulation, the vessels are normal. The blood flow is normal or maybe slightly lesser, but this one segment getting obstructed is a characteristic feature of thromboangiitis obliterans. Or the thromboangiitis obliterans also may be confirmed by the collaterals, which are characteristically seen with bulging or corrugated appearance, which is also called as corkscrew collaterals. Corkscrew collaterals are the collaterals which will become curved as due to that high pressure in that, which can be either seen in arteriography, or the Dopplers also would be showing the same. Dopplers is suggested as either triphasic or tetraphasic circulation, where you will have this blood flow in a wave form which is not the same wave form of the cardiac pulse rate, so cardiac pulse as such. So that's how it is considered as such. To confirm the diagnosis, there is a standard scoring system, and that scoring system involves the factors related to the clinical symptoms as well as the age as such. The scoring system is again mentioned as the either assessed as a positive and negative criteria. The positive criteria is if the patient has age at onset of more than 30 or in between 30 to 40, then the score is a +1. The younger the age, like nearing 30, the score is +2. If the patient has intermittent claudication symptoms, signs present as such, then +2. If it is only a history but not the definite evidence of signs, then it is +1. If there is an involvement of the upper extremity too, in such conditions, the symptom will be or score will be +2. Raynaud's phenomena is a pallor developing after exposure to the cold is a Raynaud's phenomena, or inability to flush after the cold exposure, after the pallor produced due to the cold, or time taken for the re-establishment of the color after exposure to the cold also is a part of the Raynaud's phenomena, and that is score is present as such +2. Angiography and biopsy, both of them are confirmatory, then +2 and +1 is a score given in the positive segment or positive criteria. Negative criteria are if the patient is having age at onset, of course there is one more scoring one column here in the positive, smoking history of smoking +2. If the patient is age at onset is 45 or above 50, the score would be -1 or -2. And if the patient is female, then again -1, because the incidence is more common. And if the patient is not a smoker, non-smoker, the score is -2. Then if the pulses are absent, see, in characteristically, in case of TAO, the peripheral pulses are not absent. Either they may be feeble, or there could be a paradoxical pulsations here. See, paradoxical pulsation is a phenomena where the patient may have a pulsation felt at the resting condition, but once you ask the patient to do an exercise like walking, at the end of that walking, at the end of the exercise, if you feel the pulsation may become absent. That's what we call as a paradoxical or disappearing pulse phenomena. That's also called as a disappearing pulse phenomena. Disappearing pulse phenomena is a situation where in the resting condition a peripheral pulsation is felt, may be feeble, but once the patient is made to do some exercise, at the end of the exercise, if you again palpate, the pulse will be absent, and this is due to the pulsation produced due to collateral circulation. See, if the pulsation is felt directly of the arteries, then as you do the exercise, the volume of the pulse will be increased, because during the exercise there will be increased oxygen demand, and hence there will be more blood flow, so intensity of the pulse volume will be increased. Whereas if it is due to a collateral circulation, the blood flow is relatively passive and doesn't respond to the needs of or energy needs of the tissue, but because there is an increased energy need, there will be dilatation of the vessels. The vessels are dilated, the pressure in the vessels is not proportionately increased, and hence the pulse becomes absent. Blood flow will continue, but the amount of the blood flow or the pressure gradient between the two stages of the circulation, systolic and diastolic circulation, would not be enough to produce a palpable pulse, and hence it becomes less palpable or absent, and that's what we call as a disappearing pulse phenomena. So the important is in a typical TAO, the pulses would be present, or at the most there could be disappearing pulse phenomena, but there cannot be a complete absent pulses in case of the TAO, thromboiditis obliterans. Whereas in the other conditions like atherosclerosis or other vascular occlusive disorders, the pulsations may be absent. If there is a history of arteriosclerosis, diabetes, hypertension, hyperlipidemia, that also is a negative for making the diagnosis of the Buerger's disease as such. Once you have done that positive and negative scoring, if the scoring is above more than 6 or 6 or above more than that, then there is a definite diagnosis of thromboiditis obliterans. If the score is between 4 to 5, probable diagnosis, 2 to 3 suspected, but you may have to go for the further investigation. 0 to 1 is excluded. That's how it is done. The complications of TAO may be, there could be ulcerations, gangrene, infections can occur. It results in need for amputation. Occasionally or rarely, a TAO may involve coronary, renal, splenic or mesenteric arteries, where the patient may present with the emergency symptoms, and the complications could be coronary when it is involved, the cardiac pathology, renal involved renal pathology, splenic involved when there could be splenic bleeding and necrosis, mesenteric arteries involved, abdominal symptoms could occur, but they are comparatively less frequent. As far as the treatment is concerned, there is no definite curative medical treatment. Pharmacology therapy is considered as ineffective. Abstinence from tobacco is the only measure known to prevent the disease progression. As per the current situation, stopping the tobacco is the most reliable conditions. Now, as per the data, one of the huge data seen as such, I have just copied these lines from some of the publication references here. That as per the data, among those patients who stop using tobacco, 94% of them can avoid amputation, and among patients who stop using tobacco before the progression to clinical limb ischemia, critical limb ischemia, the amputation rate is nearly zero. So amputation can be avoided if the patient stops the tobacco consumption at an early stage. In the initial stages, the whole progression of the disease can be avoided, and the complication like an amputation can be avoided in almost 100%. Whereas if the patient comes later, if the patient is aware of this issue later and continue to using the tobacco, the 8-year amputation rate is almost 43%. So almost nearly half of the patients would require amputation if they continue to use the tobacco. The other drugs which are used are to reduce the pain, symptom of pain, symptomatic drugs like NSAIDs or even narcotic analgesics could be given to reduce the symptoms of the pain. if the patient has shown the signs of ulcers or sepsis, then specific antibiotics, oral or maybe the systemic antibiotics may be given. Thrombolytic drugs like streptokinase also is doubtful, like whether it is really useful or not. The other drugs we use in the contemporary system are aspirin, platelet aggregation inhibitor, as a general protocol for treatment of all ischemic disorders, so that the clotting phenomena can be postponed or reduced, though it cannot be prevented completely. Pentoxifylline is alpha blocker, which produces a relaxation of the blood vessels, the smooth muscles of the blood vessels, and once the blood vessels are relaxed, blood circulation could improve, and that's the idea of using pentoxifylline. But the real benefit of pentoxifylline is still doubtful. There are people who claim that it is beneficial, and there are people who do consider that that's not really beneficial. Prostaglandin analogs like fetanoprost also are prescribed occasionally, and there is a claim that it gives much more results, but it's recently introduced phenomena, so much clinical information available is comparatively lower, so still it's in the initial stages of the clinical uses as such. From our clinical point of view, Kaisharogukulu, Aragyodini, Manjastari Kwata, along with the Manjastari Ksharabasti, and of course the avoidance of the smoking or tobacco is one of the most important part of the treatment, by which we can prevent many of the complications which could occur in such conditions. The other surgical treatment which could be done is a sympathectomy, done at the early stage, can produce a significant benefit, or vascular reconstruction also is another of the issue, where the blood vessels involved may be, that segment may be bypassed with the other bypassing these techniques. Bypassing techniques could be either it could be the vessels, vascular bypasses, or maybe the artificial structures, prosthetic bypasses could be used. Intraarterial infusion of reserpine is considered to be one of the measures which can produce somewhat significant benefit if it is identified at an early stage. Then spinal cord stimulator implantation is instead of sympathectomy, you use a stimulator which produces the spinal cord stimulation, so that there will be a continuous blockade of the adrenergic neurons, so that there will be vascular dilatation. It can produce a sort of mechanical sympathectomy like condition. Keeping the vessels dilated is the most important option. Sympathectomy is a removal of the ganglions, the spinal ganglions, by surgical intervention, making an incision in the paraspinal area. The surgery there earlier was very popular, but these days the popularity of the sympathectomy has become reduced because the long-term advantages are not worth of all that trouble required. Of course, amputation is the last resort when the patient has developed a gangrene and the changes are irreversible. So that's about the thromboembolitis obliterans, which is again, though not very common, but one of the frequently seen disorders. Now, the last part of this vascular obstructive disorders is a group of disorders where the peripheral vessels are obstructed, is now named as a peripheral vascular disease, and ICD code there is 173.9 is ICD code given, which involves huge different varieties of the conditions which can present with the obstructive symptoms of the peripheral blood vessels. It's also now named as arteriosclerosis obliterans. The ICD defines, ICD 173.9 code defines the clinical information of the peripheral vascular disorders. I have just copied it as such without any modification. As a symptom complex characterized by pain and weakness in skeletal muscle group associated with exercise, that's intermittent claudication like symptoms, such as leg pain, weakness brought on by walking. Such muscles limpness disappears after a brief rest and is often relates to arterial stenosis, muscle ischemia, or accumulation of lactate. That's the issue. Of course, whether it is due to the muscle ischemia or the accumulation of the lactate would be based upon the other clinical evidences like if there is a ischemia of the muscles, you will see the atrophy of the muscles. If there is not much of that condition, in the initial stages, it's due to the accumulation of the lactate. Now, the whole phenomena of the intermittent claudication is when there is a lesser blood supply to the muscles, and the muscles in the resting condition may have enough of oxygenation due to that moderate blood supply. But when the muscles are subjected to exercise like walking, then the oxygen demand increases. So the muscles may shift over to the anaerobic metabolism, and anaerobic metabolism results in accumulation of the acidic substances, mainly lactic acid. That lactic acid would be stimulating or irritating the nerves, and hence the patient would feel the pain. So once there is accumulation of lactic acid, the patient would have the pain, and that makes the patient stop walking. Or once the patient stops walking, as the muscles are relaxed, the lactic acid would be flushed away by the existing circulation, and then the patient would have relief of the pain. So phenomena of intermittent claudication is primarily due to the stagnation of these acidic substances produced due to anaerobic metabolism. And if they can be flushed out, then the symptom will be intermittent as such. Suppose the pathology is such that the amount of the hypoxia is so low that the metabolic needs of the muscles in the resting condition also is not met with, then the patient would have a severe muscle ischemia, where the patient may have a constant pain, the muscles may become atrophied, the elastic structures could be fibrosed as such, if we say chronic onset ischemia. Or if the ischemia is sudden, rapid, then there could be gangrenous changes. So that's how the symptoms would occur. But when it's a peripheral vascular disorder defined by ICD, it's about that chronic ischemia changes of any degree. Then any disorder affecting the blood flow through the veins or arteries also is again considered as peripheral vascular disease. A condition which there is a deviation from interruption of the normal structure or function of the blood vessels outside the heart, out beyond the heart, is also named as a peripheral vascular disorder. Pathological process involving any one of the blood vessels in the vasculature outside the heart also is named as a peripheral vascular. This is the exact definition of peripheral vascular disorder. It may even, in general, peripheral vascular disorders are categorized as a chronic ischemic pathology, but they also can manifest as acute onset conditions if there are emboli, thromboembolism, or acute trauma resulting in compression. Now, intermittent claudication may be the sole manifestation of early peripheral vascular disorder. So, the most important clinical presentation would be intermittent claudication. And the intermittent claudication would be either can be presented at different locations depending upon the involvement of the vessels. Aortoiliac disease has a pain in the thighs and buttocks, whereas femoropopliteal disease manifestations in the calf. Majority of the patients have pain in the calf area, but the problem would be the patient has pain in the buttock area or thigh area. There will be always a suspicion of the spinal claudication. There is a difference between these two. Spinal claudication and the vascular claudication is one of the issues. Patients who have a pathology of the spines like the disc bulging, etc., also may develop the symptoms of pain on walking. After walking a few steps, the patient may have the pain, which is the characteristic feature of the spinal claudication too, whereas the vascular aortoiliac disease also can present with the similar symptoms of pain in the buttocks on walking if the pathology is involved in the iliac vessels. To differentiate between the two, you have to depend upon the clinical history. The clinical history is a patient of vascular pathology producing this intermittent claudication, presenting with the intermittent claudication, would never have pain at rest during night particularly, there will be no pain. Whereas a spinal claudication patient would also have pain when they change the position in the bed at night. So when the patient moves about at night, there could be sudden onset of the pain. Now this can be seen in many of the patients who we treat in our hospital, because that disc bulge patients are the large number of patients whom we see, and in a large number of patients of that sort, the symptoms will be again the pain on walking, but At the same time, such patients would also have history of sudden waking up at the night when they move about at night during sleep. The reason is simple. In the night when the patient sleeps, the paraspinal muscles are relaxed, and that relaxed muscles would not be able to protect the nerve endings from getting compressed. When you get awakened, when the patient wakes up, the muscles are tonic, and the tone of the muscles protects the nerve endings or the nerve roots, and hence the pain will be lesser. But on walking again, there could be more strain on the area, and that can produce the pain, and that's how the spinal claudication occurs. Whereas in case of vascular claudication, the claudication occurs due to the accumulation of the lactic acid, and it can get flushed out when the rest occurs, and in the resting condition you will not have that kind of a situation at all. So that's how it has to be differentiated. Then characteristically the claudication patient would have a measure of the distance which he can walk, and every time the patient has the symptoms, the amount of the distance walked would be same, like a few meters, then there would be pain. In the spinal claudication, this need not be exactly the same. Spinal claudication, at times the patient may have pain in the initial few steps itself, at times the patient can walk a longer distance without pain. So this variable distance also is one of the features between spinal claudication and vascular claudication. And a patient with the ischemia, there could be collateral circulation develop, and that development of the collateral circulation may reduce the symptom of intermittent claudication, but the complications of the ischemia may persist and they can again re-emerge. See, for a temporary phenomenon, temporary phase, the claudication may subside, but again there could be another episode of the symptoms. Claudication also may present with a typical symptom of giving out. Further, the patient is not able to move at all. Once the patient reaches a limit of exertion, the patient has to are compelled to sit in and sit or maybe take rest. He will not be able to move out at all, and that is what calls a giving out symptom. Whereas in case of spinal claudication, patient may still be able to move, taking some support or some odd movements of the body, patient may still be able to move. And the other is a pain of claudication. Vascular claudication does not occur in sitting or standing position. The other clinical symptom which also may be presented, rare symptom which may occur could be lyric syndrome. Lyric syndrome is a intermittent claudication along with the impotence. When the iliac arteries are involved, the vascularity of the genital organs would be affected, and hence the patient may have an impotency also as a symptom of that lyric syndrome is the other way. Or in advanced conditions, there could be ischemic rest pain as such. The other peripheral signs of vascular diseases also are named as, are easy to remember, 5 P's, and those 5 P's are pulselessness, paralysis, paresthesia, pain, pallor. So pallor is the initial symptoms. Then there could be altered sensations. Altered sensations can be presented as a irritability of the nerve endings, where the patient may have a severe pain when you touch, or the type could be even presented as a reduced sensation. Reduced sensation to the pain also could be presented. So either it could be hyperesthesia or anesthesia also, or hypoesthesia. A regular constant pain, resting pain would be sign of a severe pathology. The skin changes are very characteristic. Initially the skin would have this absence of the sweat glands. The skin becomes smooth, rough, smooth as such, shining appearance will be seen. The vessels may seem to be dilated at that area. There could be, it looks like either bluish or reddish. Even superficial ulcers could occur, or in very advanced stages it could be a completely gangrenous conditions could occur. The skin changes which can manifest in the peripheral vascular disorders are quite common. One of the standard measure to confirm peripheral vascular disorder is ankle brachial index. Of course, in our setup we rarely do this clinical test as such, because most of the patients with peripheral vascular disorder would have a generalized atherosclerosis, and hence the ABI or ankle brachial index may not be positive in many patients or may not be in the remarkable condition. But in the other conditions where the patient doesn't have an atherosclerosis, obvious atherosclerosis, assessment of the blood pressure in the upper limb and the lower limb at the ankle, the brachial blood pressure and the ankle blood pressure has to be assessed, and it's calculated by dividing the highest or the maximum pressure in the ankle to the maximum pressure of the arm, and the average would be like the arm pressure would be always slightly more, and whereas the lower limb ankle pressure would be lower. The ratio is 0.91 to 1.3 is the normal. If it is 0.4 to 0.9 at that level, it's moderate peripheral arterial disorder. If it is 0 to 0.4, then it's a severe peripheral arterial index or pathology. Another of the clinical tests which is done to confirm the peripheral vascular pathology, particularly in the upper limb, is Allen's test, or the same Allen test could be modified in the lower limb too. The Allen test is done with the method where these tibial and ulnar arteries are compressed with the fist closed, and it has to be compressed for 2 minutes, and the patient has to keep the arm open, and once you release the pressure, normally there will be a flushing. See, as you press the vessels, the palm becomes somewhat pale, and normally there will be a flushing immediately, whereas if the flushing doesn't occur, or if there is no backflow of the blood again and delays that, the pallor remains for a longer duration, then we say that Allen's test is positive. This also is one of the signs as such. Confirmatory evidences are by the Doppler study. The Doppler study may present with the biphasic, triphasic or tetraphasic presentation, suggestive of the severity. Biphasic is moderately severe, and biphasic in the sense you will have a wave which is above and below that baseline. Triphasic is in one pulsation you have one spike and one below baseline and then another above. The wave will be having that way. Tetraphasic is there are 4 components in each pulse that suggests of a severe ischemic pathology as such. The more the ischemia or greater the atherosclerosis, the greater the evidence of severe. Treatment, of course, the treatment for these conditions would be again with an idea of preventing the complications. It would be the present prescribed drugs are platelet aggregation inhibitors, anticoagulants like even heparin may be given, pentoxifylline, as I said earlier, which are clasazole also, which is a vasodilator. Statins are very frequently prescribed in the present day situation. Beta blockers like atenolol also are prescribed. AC inhibitors, the antihypertensive drugs, may help in reducing the blood pressure. Now these days the other techniques like revascularization interventions like bypass and these arterial reconstruction, such procedures are also tried, but they have very limited benefit. Virtually there is no curative treatment. From our treatment point of view, Kaishore Arogya Manjisthalika Sharabasti can be treated. All these vascular conditions we can consider as a Vata Rakta and manage with the same line of treatment as such. So that's with this we will conclude today, and next part we will discuss about atherosclerosis as a pathology. If there are any questions, we will try to answer and then when okay, there are no questions.